Good afternoon, everyone. My name is Chotika Suwanpanich, and everyone can call me James. I'm gonna take off your mask. I take off my mask, okay. I'm a research assistant at HTAP Thailand, and on behalf of the research teams, I would like to take this opportunity to present an expert illustrations to estimate the counterfactual scenario for economic evaluations of precision medicine project. And this is outline for today. Start with rationale, go to the objective, method, result, conclusions, and our policy recommendation. First, this is the rationales. I will spend time with this part because of there is a new word, new terms, and new definitions of this study. And I'm going to start with a short introduction to everyone about the precision medicine. Precision medicine as the innovative approach that use the individual genetics informations or environment or lifestyle informations to guide the decisions related to their medical management. For example, of the precision medicine is the exome sequencing, or from the next I will call it EX. This is the genetic testing to identify the genetic cause of the infantile intractable epilepsy. And we use this technology to represent the precision medicine in this study project too. Nowadays, precision medicine still high cost and niche market. Therefore, economic evaluations is very important to the decisions maker to include the technology in the public reimbursement program. When we start the economic evaluations, which is the study which presents at the morning for the exome sequencing technology, we found the problems that the comparator, or we call it counterfactual scenarios, in this study is the standard practice. It was lack of information because of its rarely feasibility and sometimes it's unable to conduct the control groups. After the review literatures, we found that the current research deal with the problems with the methods on the left hand on the slide. The physicians in the research teams who know the ES results pretend to not know the ES result and thinks what would they should do if they don't have the ES. What would they should do is mean what would they investigate or treatment or diagnosis patients. And this approaches raise the questions. This approaches raise the questions of unbiased, and this study is named, this approach is unbiased self-control. And this is approach raise the questions as unbiased self-control groups may create bias in data used in economic evaluations compared with use the methods in the right-hand side, which is the physician who really don't know the ES results and thinks what would they do. So the objective of this project is to compare cause and outcome between unblind and blind self-control groups in estimate the counterfactual scenario using in the economic evaluations. This part is the method. This study is an experimental study by using expert elicitations on 3 real patients' cases. The sample is 14 experts were recruited and randomly assigned into 2 groups, 7 for unbiased self-control and 7 for blind self-control. And we collect the data by the workshops occur in persons, 2 groups were outside and separate rooms and asked to perform elicitation tasks. The unbiased self-control group will inform the final diagnosis by ES results, but asked to perform the elicitation task if they don't know the ES results. But by self-control groups did not inform anything about result before they do elicitation tasks. And For the fewer patients cases, we sampling from the cohort intractable epileptic pediatric patients who had undergone by ES. And this table show the characteristic of each case stratified by the advantage of the ES. For case 1, standard diagnosis practice and ES cannot found the final diagnosis. That standard practice is, for example, CT scan, MRI, EEG, etc., except the genetic testing. And for case 2, standard diagnosis cannot found, but ES found diagnosis. And for case 3, both of standard diagnosis and ES found the the final diagnosis. This is the elicitation tasks we are expert to perform, including the investigation, treatment, and write the possible diagnosis, and with the person confident each the possible diagnosis they write. And this is the primary outcome. We measure the total direct medical cost, which including the laboratory cost during investigation and treatment costs. And for the secondary outcome is the accuracy of the final diagnosis. And this was we finding for the primary outcome. The slide show different costs between the blind group and unblind group, and separate in types of the case, and show in the US dollar. And for case 1, both of standard practice and exome sequencing can found the final diagnosis. For case 2, only EX found the final diagnosis, and for case T, both of the standard practice and ES found the final diagnosis. We found that the blind group had a greater mean cost of investigate, but lower mean cost of treatment than the unblind group for all 3 cases. But difference was not significant. And the next one is the accuracy of final diagnosis. We compare the mean of % confident of correct diagnosis between groups, between blind and unblind groups. The results show the only case 2 was difference of accuracy, and we can explain that accuracy depends on the type of the disease presents. For case 1, undiagnosed case by ES, and case 3 easier to diagnose without EX. So there is no advantage to knowing the final molecular diagnostic testing before the due elicitation task. But for case 2, unblind group had a greater advantage diagnosis accuracy because of the patients who have a very minimal chance to be diagnosed without EX. So knowing the final diagnosis may have a false high accuracy of the clinical prediction. And for conclusion, in the total direct medical cost by self-control group was higher cost of investigations, even it was not significant, but could be implications in the economic evaluations. And for predict clinical outcome, use of unblind self-control approach can overestimate the outcome of the counterfactual scenario. And by self-control approach should be preferable options to collect the cause and the outcome parameter for the counterfactual scenario when no real clinical data unless the further research suggests otherwise. The last one is our policy recommendations. We recommend the unblind self-control approach as a preferable when using expert elicitations to evaluate the counterfactual scenario of economic evaluations of the precision medicine. And thanks for your attention. That's all for today.
Thank you very much, with 40 seconds to spare, so great job, and very nice presentation. So I guess we can start with our commentators. Is there some questions for the presenter?
Thank you. That was a very lovely presentation and very important. I think when we start thinking about genomics and sequencing and the difficulties that we have finding evidence for the comparator. So very elegant approach. I'm just wondering, in the study design, you had the 7 allocated to the blinded group and 7 to the unblinded. And I just wondered why you didn't instead have 14 initially blinded and then unblind them so that you could actually see what the change in practice would be by receiving the ES results.
Could you repeat the questions again? It means that why is 7 for each group?
So instead of having 7 in each arm, so a head-to-head comparison essentially, you've got why not have 14 before and after? So 14 before and then 14 after.
14 before and 14 after. Okay. Because of our study design, we used the 3 patients' cases in the real world, and when we need to separate the experts because of when use the 3 cases, they will know the final diagnosis and pretend to don't know and what they do if they don't know. But if I use pre and post, 14 for each group, they already know the result. This is the question? No.
Okay, so it's just because you've got so many, you're presenting them with multiple cases. Is that the?
Everyone do 3.
3, yeah.
Yeah.
Okay.
May I follow up with Sarah? I'm wondering, because this is an experimental study and you come up with 7 and 7, whether you calculate the sample size and why only 7. And also I have a question, when you do your data analysis and then the table, you mentioned that you do regression. Can you also mention about the regression that you did as well? Because like in the table it's like a difference between the 2 groups, but it's not really something about regression that you have in the table though.
First, I answered about the sample size. We didn't calculate the sample size before because this is maybe the first experimental study that happened, so we can find the number of sample sizes would that would be, and we do follow by the guideline of the expert elicitations, and they recommended you should do about minimal about 5 to 10 expert per arms, and 5 to 10 expert, the minimal number. And the last question for
the regression, whether you do a regression analysis or not, because it's in the table though.
In the table.
Or maybe you didn't, or I might miss it.
Can share the slide, please? This one, right?
Linear regression though. Yeah. What is your y and what is your x though? Or it's not just only the difference between the 2 groups?
Sorry, I can answer this. I can answer this analysis because I'm involved in the process of the design. This one, sorry for that. But if you want the answer, maybe I can give your email and then I will send it later.
Okay, great. Yes. So we'll take some questions from the audience. So please go ahead.
Hello. Hi. Actually, I just want to help follow up.
Okay.
Jam actually helped with the regression, but only initially. So the reason, linear regression, you absolutely right. So it's pretty much just, when it's simple linear regression, it's like using t-test, right? But at the same time, we know that when we were trying to explore, we have 3 cases, and each individual will have 3 answers. So we explore both GEE model, just trying to capture the repeated measure on different cases. So there was different way to explore, and in terms of the sample size, we follow as Ms. Chotika highlight, like it is an experimental study, but it's very unique in the way that it's more focusing on the deliberation process of how we can get input from experts. So the sample size calculation was not done in the traditional sense, but I think both commentator highlight great point that our team can take back to. Thank you.
Great, thank you. Are there other questions from the audience, or if people want to either put it in the app or come to a microphone? We have a few minutes left of this. I will ask one question. Actually, on the table that you just showed, there was you might have mentioned it, but there's a really large difference in the treatment costs in that group 2. It was like 800 something in treatment costs, and the other 2 groups were quite small in the treatment costs. So could you just elaborate a little bit further on why that was the case?
I think it's maybe from the characteristic of the case 2 is can find the final diagnosis with exome sequencing compared with the standard practice. Only exome sequencing can find the final diagnosis, and when they know what is the diagnosis, really know the final diagnosis, they have a specific treatment that physicians order, and there's the reason why the treatment cost in case 2 is higher and look different from the others.
Okay, yeah, because that seemed to really be affecting then your cost effectiveness outcomes in that group. Okay,
Yeah.
but that's good to understand and to hear more about that. Okay, are there any more, or if you put it on the app, just let me know. I can check also. I don't see any. So, all right, any further questions? If not, we'll move on to the next presentation. Thank you so much, Chotika.
Thank you so much.
And if I have